Yes, definitely.
Good evening, Mr. President and President Emeritus.
Good evening, sir. We are always we're always delighted to hear your voice and to see you on your platform. Thank you so much for your support, sir.
Yes. Oh, thank God. How are you guys doing?
We thank God, sir. Your consistency is a source of motivation for us, sir. You've hardly missed any meeting. I think I can count with one of my hands the number of times you've missed a meeting, and they are for genuine reasons, and you always send apologies ahead. We are really very grateful for all of this, sir.
I benefit from fellowshipping with you guys too. Just, it links you back home and just, exchanging ideas with fellows and colleagues at home. So it's a two-way beneficial thing. So I'm thankful that I'm part of this and you guys are over there. If you are not there, we won't be here.
Thank you very much, sir, for the kind words. We are grateful, sir.
Thank God. Sure.
I also forgot that you are also another man of people too. You are multilingual in Nigerian language. You know different people, different corners of the country. So I know people will be joining us at the top of the hour, and because we have a packed agenda today, I suggest that we start at the time allotted, and then people will join us as things go. I hope that's okay by the house.
Yes, if I may plead for 3 to 5 minutes of grace, probably some people are having some network glitches. So I think we can start 805. 805. Okay. Yes,
yeah,
805.
Yeah, that 805 will be fine, just to give some people, more people time to. I know you don't want to encourage African time.
Yes, we do not want to encourage African time. I know some people say that if you are on time, you are 5 minutes late for a meeting. But definitely things can happen. So I think it's fine.
Yeah, Mr. President, Professor Bakari just joined us.
Professor Bakari, you're welcome, sir.
Thank you very much. Thank you very much.
Thank you. Professor Bakari also he called to confirm the timing and everything, and it's always been another source of support for us. So thank you so much, sir.
Yes, thank you very much. Because I was on the road, I was coming to Kano when I called you that time. I just arrived Kano now.
Yes. Thank you, sir. We thank God for joining me, sister.
All right, thank you.
Professor Bakari, Ranka Dede.
No,
you
have not forgotten my degree.
No, sir, no.
Thank you, sir.
Yeah, how was your trip? I hope you got there safely.
Yes, I'm in my hotel now. Just now I entered my hotel, so I said, let me open it.
Thank God.
Yes, sir. Thank you, sir.
Hello.
Hello, Dr. Rosala.
Hello, evening.
Good evening.
Good evening, sir. Welcome, sir.
Justin, how are you?
I'm okay, thank you.
iPhone the Augustine.
I think he has shares with Apple.
Yes.
He's always promoting them. Thank you so much for joining us from the place. We are grateful, sir.
You mean I'm not visible?
Yes, we can see, sir. Oh. And I think you have a book of shelves behind you, or shelf of books. I don't know which one to say.
A book of shelves. Okay, that's all right.
Yeah. Professor Rayofo, you're welcome, sir. Thank you for joining.
Good evening, Professor Rayofo. You are welcome, sir. It's nice having you around.
How are you?
Fine, sir.
Thank you. I'm good.
Welcome.
Professor Rabo is in the house, sir. Please, Mr. President. Professor Rabo is in the house.
I just saw him now. Professor Rabo, you're welcome, sir. Thank you so much.
Thank you very much. Thank you.
Grateful, sir. Thank you for your consistency too, sir. We are grateful. And we agreed before most of us joined to give 5 minutes of grace for people who have network issues. So please just bear with us while we give 5 minutes for people to join.
Okay.
I think we have more people coming in now, so we'll just give 5 minutes, please. I'm so sorry for that. And there are so many people joining now. I know we're not able to call all the names, but I've just seen them randomly. Professor Oshinowo from Lagos, you're welcome, sir.
Welcome. You're welcome as well.
Thank you, sir. Dr. Clement Ojon, you're welcome, sir. And
thank you very much, Dr. Adibola.
Yes, you're welcome, sir. Thank you, sir. Am I correct to say that I'm seeing Dr. Lewis Roberts online? Am I correct, sir?
Hello, good afternoon, good evening.
Good evening, sir.
You're welcome.
It's been a long, long time, sir.
Yeah.
Yes, it's a pleasure to be here.
Yeah, we have celebrity in the house, sir.
You're
Thank you
welcome,
so much
sir.
for joining, sir.
Are you there?
Yes, we can hear you, sir.
Okay. All right. All right.
So again, there are so many names in the house. I don't want to leave anybody and on call, but I'd like to appreciate you all for joining. Again, like I said earlier, we're waiting for a couple of minutes for more people to join us based on the consensus we
That's
had.
good.
Yeah. So we'll start at 5 minutes past the hour.
Okay, and while we're waiting, I'll paste the attendance register in the chat box so we can be filling that. Let me paste that. Thank you.
Thank you, please do that. Thank you,
All
sir. That can have record for our attendance.
Okay.
Dr. Kenechukwu, it looks like you stopped sharing your screen.
Me?
No,
Okay.
Dr.
Let me
Kenechukwu,
put it back.
our speaker.
Okay.
Yeah, let me get it back on.
So the link to the attendance register has just been shared on the chat platform. Please do kindly click on the links for our records, please. Thank you so much.
Okay.
And Dr. Kenechukwu, are you still having issues with your slides?
No, let me put it back on now. I've seen.
Yes, we can see it. Thank you.
All right.
So it's 5 minutes past the hour and we can start now. So good evening, everyone. Thank you all for joining. My name is Dr. Ademola Adeye. I'm the president of the Nigerian Society for Colorectal Disorders. And on behalf of the ESCOs, the Board of Trustees, and all the members, I'd like to welcome us all to this meeting. Today is a special occasion because we have a webinar, which we're all looking forward to, as well as our annual general meeting, the AGM, immediately after the webinar. Our speaker today is no other than Dr. Kenechukwu Chudy-Onwugaje. He's the Medical Director of Red Cross Center for Digestive Health in Lagos, and also the chair of International Relations Committee of the American College of Gastroenterology. So he's going to speak to us today about advanced endoscopic interventions in the management of gastrointestinal malignancies. I'm sure that we're looking forward to this with rapt attention. And as usual, there will be a Q&A session at the end of this talk. You can always post your questions and your comments on the chat function of the Zoom function. And our rapporteur will also speak and moderate that aspect of the program. As always, this program is being recorded and after being edited, it will be posted on our different platforms. Without further ado, I'd like to hand over the platform to Dr. Kenechukwu. The floor is yours, sir.
Thank you very much for that. Good evening, everyone. And for some people, it's good morning for them. For some people, it's good night for them, like Dr. Wasi, who is in Korea. It's my pleasure to join you all to give this talk. I know of the great work that the society has been doing over the last few years, and I'm just pleased to be here. I'll be speaking on advanced endoscopic interventions in the management of digestive health cancers. And just some of the goals that I have for this talk is that we understand the burden of digestive health cancers, especially in the African continent. I will define interventional endoscopy and just some of the details surrounding it. I will talk about some of the procedures that we do, and particularly want to focus on the management of colorectal polyps and early stage colorectal cancer, the use of endoscopic ultrasound and ERCP in managing pancreatobiliary cancers, and use of gastrointestinal stenting for managing esophageal and gastric malignancies. These are some of the interventional endoscopic procedures and techniques that we have. I'm also going to center a lot of the discussion in cases that we have done here in Nigeria, so make it very locally applicable for us. So just to start, the burden of digestive health cancers is significant. We know that cancer accounts for 1 in 6 deaths globally, and it's a significant public health issue. In 2022, there were 20 million cancer cases and about 10 million deaths from cancer. But if you look at the cancer deaths, about a third of all cancer deaths are from cancers involving the digestive tract. Colorectal, liver, and stomach cancer make up in the top 5 causes of cancer deaths. And if you look at this, with the incidence and the mortality, with the mortality after lung cancer, we have colon cancer at 9.3%, and we have liver cancer following it closely. Then you see stomach cancer 6.8%, pancreas, esophagus cancer. So just in terms of deaths itself, is a significant burden. And if you look at the African continent as well, with the data that we see, we find that the case fatality rate from this cancer is even much higher in the African continent. And most of it is due to just the delayed diagnosis that we see. And in most cases, diagnosis is delayed because patients we just don't have access to the endoscopy that we need in most cases to diagnose gastrointestinal cancer. Now, regarding interventional endoscopy, what is it? It's a subset of gastroenterology where we employ advanced technology and techniques with the endoscope to diagnose and treat diseases in the gastrointestinal tract, in the bile ducts, and the pancreas. And this is something that has grown over the last few decades. And it's there to, in many cases, to support surgery, in some cases, to actually replace surgery because of the minimally invasive approaches that we use. It helps to ensure that most patients recover faster, hospital stays shorter, and there's reduced complications when we do things in a minimally invasive way. Some of the common procedures that we have in interventional endoscopy include endoscopic mucosal resection and endoscopic submucosal dissection that we use for colorectal polyps, early colorectal cancers. We have ERCP, we have endoscopic ultrasound, and we have stenting of the GI lumen. And I'll talk a little bit more about some of these. Now, why is all of this important? It's important because we have a significant burden of digestive disease on the continent, but yet access to advanced endoscopy we find is still very limited. This was a survey that was presented at the AHP-BCC meeting in 2020, looking at multiple countries below the Sahara on the continent to see how many centers have access to ERCP or to endoscopic ultrasound. And I think some of this data was even being more generous. If you look at Nigeria at the time, we said we had 5 centers performing ERCP and 1 performing endoscopic ultrasound, but you can see that multiple countries on the continent just had 0. And so there's still this need to promote and to build the practice for these procedures and just for interventional endoscopy just in general. Now, I'll start with colorectal cancer. With colon cancer, we know that there are about 2 million new cases globally every year with about 900,000 deaths. It's the 3rd most commonly diagnosed cancer and 2nd leading cause of cancer deaths. And if you look at the global data, about 90% of these cancers occur after 50 years of age. So it's not a cancer of the young globally, even though we're beginning to see early onset colorectal cancer. But if you look at the African continent and all of the data that we have so far, the predominant pattern we actually see is just early onset colorectal cancer on the African continent. We don't have a lot of robust population-based studies on the African continent for reasons that we all know to explain this. But if you look at this paper and this table here, and if you follow me, this table is looking at what proportion of cancer cases in this population studied were in people younger than 30 years of age or those younger than 40 years of age. And if you follow me here, if you look at the USA, for example, in the USA, only 1.9% of colorectal cancer cases that they found, population-based studies, were in people younger than 40 years of age. But if you look at studies on the African continent, now most of these studies were single center-based studies, but the numbers are just so different. If you look at Lagos, for example, 23% of colon cancer cases were in those younger than 40. Look at Ilorin, it was 30%. But if you go beyond Nigeria, you look at South Africa, it's 22%, 19%. And now if you say, well, these are all single center studies, one population-based studies, the study that was done in Egypt that had more people, 22% of the colon cancer cases they saw there were in those younger than 40 years. This is very different from what we see in the West. And we can't explain what is going on yet, but I'm sure most of you in your practice have seen a lot of cancer cases in people who are less than 50. And so it's a very different pattern. This calls more for more conversations about screening. But how do colon cancers develop? We know that cancers start at first as small polyps, which grow over time. There are two specific pathways, either the adenoma-carcinoma sequence or the serrated pathway through which we have colorectal cancer develop. And our goal at all times is to catch these things early when they are still polyps or early stage cancers, and then resect them where a cure can be achieved. And there are things that can really help to reduce the risk of cancer, but also for cancers developing after a first resection is done. Things like ensuring that we resect it completely, that we do appropriate surveillance at the right time, depending on what we see, and that we're maintaining some metrics that are important, such as the adenoma detection rate and keeping track of our numbers. Now, just with regards to polyps that we see in the colon, before we do a resection, there are things that we look at to try to assess what is the risk of malignancy of this polyp. The Paris classification is the most widely validated system that we use. And with this classification, it can help us to predict the risk of malignancy in a polyp. And there are different types. There's the polypoid lesions. And for the polypoid lesions, these are lesions that are about greater than 2.5 millimeters above. And so 2.5 millimeters is if you appose a closed biopsy forceps to that polyp. If the height is greater than that, then that's a polypoid lesion. And you can have the pedunculated type, which is the 1P, which has a stalk. We can have the sessile type, which is broad-based without a stalk, and the stalk pedunculated. And then this can also be non-polypoid as well. And you can see, just based on the pictures we have here, what this look like. And then you can have the lesions that are just fully excavated like this as well. Now, with pedunculated lesions, these tend to grow from the underlying mucosa, and they have a narrow stalk to them. Because they have that stalk, there's more separation between the neoplastic epithelium and the underlying mucosa. While for the sessile lesions, we don't have as much separation because they don't have a stalk. Now, just in general, small polypoid lesions that don't have any alarm features, that are not too concerning, they are benign in most cases, and they can be removed without any issues during a colonoscopy. But when lesions have a depression with them, lesions with depression have an increased risk of malignant disease. And we know that depending on the size of how deep the depression is, if it's 6 to 10 millimeter, you have a greater than 40% risk of malignancy. And if it's greater than 20 millimeters, the risk of malignancy increases dramatically to about 90%. And when we have non-pedunculated lesions with ulceration, in most cases, these are almost always advanced cancers. Besides the Paris classification, we also know that we do colonoscopies where we see laterally spreading tumors, just like this. Now, laterally spreading tumors are superficial non-polypoid lesions that are larger than 10 millimeters, and they have a lateral growth pattern. They just spread across. And there are different subtypes that we see, which also help us to understand and predict the risk of them having cancer in them. Now, the two major subtypes we have are granular, non-granular, but within them, so within the granular subtype, we can have the homogeneous granular subtype, which is what we see in figure A. And with figure A, the risk of malignancy with these lesions is about 0.5 to 2%. But for the nodular mixed type, which is what we see in figure B, is about a 10% risk of having malignancy in them. And then for the non-granular lesions, we can have the flat ones, which have a 5% risk. And that's what we have in figure C, while the pseudo-depressed have an even much greater risk of almost 32% of malignancy. And that's what we see in figure D. And so there's the Paris classification, there's this laterally spreading tumor types, and the goal is for us to be able to, based on what we're seeing, get a sense of the risk of malignancy, and then go ahead to decide how to resect them. Now, there are different considerations we have when we see a polyp and how to resect them. Typically, if you're doing a colonoscopy and you find a small polyp less than 5 millimeters, it's almost always benign. You can use a cold forceps. Ideally, if you can use a cold snare, that's better, so that you're not having to go and do multiple bites with a cold forceps, which sometimes you can have like remnant tissue remaining there. If it's between 6 to 9 millimeters, the idea is to do cold snare polypectomy to take those out. If it's between 10 to 19 millimeters is sessile, the cold snare can take this out as well without any issues. Some people are more comfortable with hot snare polypectomy, depending on what it looks like. And if it's the one that you think may need a lift before you do a hot snare, then you can do endoscopic mucosal resection for these ones. Now, when it gets to more than 20 millimeters, these are the larger lesions now. You can do endoscopic mucosal resection where you inject, lift it, and then you snare, you do a hot snare. Sometimes, depending on what you have available, you can lift it with saline. If you think there's a high risk of bleeding, there's a bigger polyp, you can mix in some epinephrine into it before you inject, so that reduces the risk of bleeding. If it's much larger, it might require piecemeal resection, and that's fine, as long as you make sure we try to get out all of the polyp. But for the much larger ones as well, endoscopic submucosal dissection can be ideal in many cases, and we'll go into more detail in which cases you prefer ESD to endoscopic mucosal resection. Skill set is available. Now, the other things to consider for ESD is if you suspect that there's some mucosal invasion, if it's a laterally spreading tumor with the non-granular type, and if it's a large lesion in the rectum. The other things to consider is if the lesion does not lift when you try to lift it, it looks very scarred, it's in the appendiceal orifice. These are situations where you may want to consider endoscopic full thickness resection if we have the specialized device for it and the skill set for it. If that's not available, then they may require surgery for this. For those that have a polyp that's pedunculated and has a thick stalk, in this case, you may want to do a hot snare and do prophylactic clipping to reduce the risk of bleeding. If the stalk is very thick, you may also want to inject epinephrine into the stalk just to reduce the risk of bleeding. Or if you have a device called an endoloop, is a loop device that you can put in around the stalk at the bottom of the stalk to sort of tie up the blood vessel before you now resect it just above it. And that reduces the risk of bleeding as well. Now, when you have large lesions, how do you decide between whether you want to do EMR versus doing endoscopic submucosal dissection? Well, first of all, the skill set has to be there to be able to do both. But some considerations are, if it's a large lesion that is clearly benign, then you want to go with endoscopic mucosal resection. If it looks like there may be some invasion, then ESD, if that's available. Now, the advantages with doing ESD is that allows for resecting it all together as one unblock resection, while with endoscopic mucosal resection, with these very large lesions, we often have to do them in a piecemeal fashion to get it all out. But the advantage with EMR is that this is usually shorter. It's not a long, complicated procedure, and the risk of complications are also very low. With endoscopic submucosal dissection, there is the risk of bleeding, which is higher, risk of perforation, and some patients can develop post-polypectomy syndrome as well. And so these are things to keep in mind, but also to counsel the patients on beforehand so that if these things happen, they know it can happen. But we on our own end also try to anticipate and prepare for these complications. In terms of the recurrence rate, the risk of recurrence is much lower with ESD, and that's primarily because we're resecting it all together at once, and we almost always get negative margins. And that's a requirement for ESD. Also, in terms of the histology, because you have just the whole tissue all in one, it's just much better for histologic assessment when you do ESD compared to endoscopic mucosal resection. So these are the considerations that we should have when we're resecting colon polyps or early stage colorectal cancer. Now I'm going to go over some clinical cases as we go into discuss more of the pancreatobiliary topics now. Now this is a patient who we saw here in Lagos, 73-year-old woman who has a history of breast cancer. She'd had treatment for her breast cancer about 2 years before coming to us. She suddenly developed pain in the abdomen and then had progressive weight loss over 2 months. They got a CT of the abdomen and pelvis, and they found an almost 6 centimeter solid mass in the pancreatic tail. And this mass was not seen when she had a CT done 1 year prior. They got some labs, and the labs showed that her CA19-9 was markedly elevated. And so the question here was, is this, recurrence of her breast cancer with mets to the pancreas? Is it a primary pancreatic malignancy? What's going on? And so she was referred to us. And the question is, how do we evaluate this? So how do we look through the GI tract to get to the pancreas to see what's going on? This is where endoscopy and ultrasonography has been combined for us to be able to do endoscopic ultrasound. And you can see here, just based on the anatomy, that the pancreas is just solidly behind the stomach. The head comes in and wraps around this area, in the duodenum and the bend of the duodenum, and then the tail goes out towards the spleen. But most of the body of the pancreas is behind the stomach. And so with a scope within the lumen of the GI tract that has the ultrasound probe, we can see clearly what's going on the outside. And we can not just see, but we can also biopsy as well to get tissue to confirm diagnosis in this patient. Now, endoscopic ultrasound has progressed over the last few decades. We've gone from first having the radial scope to developing a linear scope, through which you can now put in a needle to get biopsy lesions within the GI tract. And our needles have also improved dramatically over the last 20 years or so. We now have gone from needles where we could just do fine needle aspiration to needles now that can give us core tissue, fine needle biopsy. And that's where we are right now with endoscopic ultrasound. In terms of the indications for endoscopic ultrasound, the diagnostic ones include, like in this patient that we talked about, trying to evaluate lesions in the pancreas, whether it's solid lesions or cystic lesions in the pancreas, being able to go in, take a sample and get a diagnosis. But it's also used for evaluating submucosal lesions in the GI tract. When you see a lesion that looks like a gastric cyst, for example, this is what you want to use to evaluate it and get biopsies. It helps with staging GI cancers and also to evaluate suspected cholelithiasis too. And there are also therapeutic indications for EUS. It can be used to drain pancreatic fluid collections. It can be used for celiac plexus neurolysis, where for lots of patients with pancreatic cancer, they develop severe debilitating pain over time, and this can help to relieve that. It can be used to place fiducials when we're trying to help the radiotherapists direct their cancer treatment for patients. We can use it for EUS-guided ablation therapy for cysts. It can be used for EUS-guided anastomosis as well. We have many patients who may come in with mass in the pancreas. They have gastric outlet obstruction. We can now do EUS-guided gastric jejunostomies to provide relief for them, because most of these patients are really too sick to withstand surgery. And we can also use EUS for vascular interventions as well. So for the patient that I talked about, we did her endoscopic ultrasound at our center, and we found a hyperechoic lesion in her pancreatic tail, which measured about 5.5 centimeters for this patient. We were able to clearly see it, and we were able to biopsy this lesion. This is a short video of us doing a biopsy. It's fine needle biopsy, and you can see that with the fine needle biopsy, we were able to, you can see my needle going in back and forth in the lesion to sample it. And with this, we're able to obtain tissue from this patient. And the pathology report came back and it confirmed that this was pancreatic adenocarcinoma for this patient. And the patient was able to go on to see the oncologist and go on with her care with the oncology team. But this is just one of the examples where this is important to help us get tissue to determine what we do next. And before now, when this has not been readily available, we have tried to do different things to get tissue. Sometimes patients have had to go to open surgery to explore and try to biopsy the pancreas and do different things. But the idea would be to do this in a minimal invasive fashion with endoscopic ultrasound. And with this, we really are getting core tissue for this patient. This is what it looks like. And so the pathologist has enough to look through and see what's going on. And if they have to do more studies, they have the core to do more studies on the tissue. Now, pancreatic cancer, as we know, is the fourth leading cause of cancer deaths in the US. We don't have population-wide data in Nigeria to know what our numbers are, the absolute numbers are. But we all know in our practice that we see this often. Patients coming with obstructive jaundice, weight loss. We're seeing it more and more now, and we're seeing it younger and younger too. In the 50s, we had someone here in their 30s. So these things are happening. We know that age is the strongest risk factor, but we also know that over the next few decades, that all the studies show that we expect that the incidence of pancreatic cancer here on the African continent will rise. For this reason, it's really vital that we incorporate EUS into our practice, because it's useful not just in diagnosis, but also with staging pancreatic cancers, palliation for those that need celiac plexus neurolysis, for example, but also to screen for pancreatic cancer as well. We know that if you look at endoscopic ultrasound and you compare it head to head with CT and with MRI, it's been shown to be much more sensitive and specific for detecting pancreatic malignancy, especially when it's for pancreatic masses that are less than 2 centimeters. And it's not just that we're able to detect these masses, but at the same time can perform fine needle biopsy to get tissue for diagnosis. More importantly, if these patients have jaundice, for example, from a mass that's compressing their bile duct, at the same session, they can have the endoscopic ultrasound done and have the ERCP done to place a stent for them to relieve the obstructive jaundice. It's also important for staging as well. Some patients may come in and they already have a lesion in their liver. If possible, during the session and there are metastatic lesions in the liver, those can be biopsied to confirm if it's the same mass that's spread to the liver. It's also useful to screen for familial pancreatic cancer. We know that there are genes that are associated with increased risk of familial pancreatic cancer, like the BRCA1 and 2. And so in places where these things are known and people have these genes, they are just followed with time and they have EUS done to screen them. And we having patients now in Nigeria that have been discussing these things with us. I had a patient recently here in Lagos whose mother died of pancreatic cancer in her 50s. He's in his 40s now, and he was asking, what can I do? How do I know? Luckily, there's a service in Nigeria now where people can commercially get a pancreatic cancer hereditary screen done. And they do it for multiple cancers as well. And so we said, okay, go and test and see if you have these genes, then we can decide if you need to get on the screening program to know your risk and to be able to detect cancer on time if you have the genes that predispose to it. Now, this is another case that we saw here in Lagos as well. And this case, I use this case just to highlight what we talked about, that EUS is more sensitive for lesions that are smaller. This was a 55-year-old man who came to us. He was referred after presenting with generalized weakness, itching, yellow eyes, just the things we typically see with obstructive jaundice. His CA19-9 was not impressive, though it was just 14.9, but his liver numbers were all very high. He was deeply jaundiced. He had an abdominal CT done, which had shown some dilation of the extrahepatic and intrahepatic ducts, but the pancreas was reported as normal. Pancreatic duct was not dilated. They went on to do the MRCP for him, which also showed some dilated ducts as well, and possible stricture at the level of the head of the pancreas, but they clearly said that there was no mass seen as well for him. And so he was sent to us, the plan was for us to do the ERCP and do the endoscopic ultrasound to see what's going on. And so for him, we did endoscopic ultrasound, and you can clearly see here that there is a hypoechoic circumscribed lesion on the pancreatic head. This measured about 27 by 20 millimeters for him. And you see the look of this is sort of very homogeneous. This is sort of the look, just based on my experience and based on all the studies, this kind of look that you see with neuroendocrine tumors more than you see with adenocarcinomas. We biopsied this lesion, and the lesion came back and it confirmed that this was a neuroendocrine tumor for this patient. And again, like I said, EUS has a superior sensitivity compared to CT or to MRI for pancreatic lesions that are this small. And so when we didn't see anything on the scans, it may be useful to pursue endoscopic ultrasound to try to take a closer look at the pancreas. Now, for this same patient, we also had to do at the same session, do the patient's ERCP to relieve his obstructive jaundice. So what is ERCP? It's an interventional procedure that we do where we combine endoscopy and fluoroscopy at the same time to allow us to evaluate the pancreas, the pancreatic duct, and the bile duct, and to treat diseases that involve both. And so for these patients, when we're doing them, we're looking at both screens at the same time. We can recall from our medical school that this is the common bile duct. We go up this way, we have the cystic duct that takes off. We go here through the common hepatic duct, we go into the liver as well. On fluoroscopy, this is what this looks like on fluoroscopy. So on fluoroscopy, we can see the common bile duct that goes up this way. And we can see the cystic takeoff here. We can see that there's some stones in the gallbladder here. We can see these filling defects, but we can see the left and right hepatic ducts going into the intrahepatics. Now, on this other end is the pancreatic duct. The pancreatic duct will go across the spine. That's how we know and we can differentiate when we're trying to cannulate, whether we're in the bile duct or the pancreatic duct. Bile duct goes up, pancreatic duct goes across the spine. And some of the common indications for ERCP include benign indications like common bile duct stones, bile leaks that the surgeons and you guys often see when you do cholecystectomies. These are some of the benign things, and some benign strictures as well. But we also have patients that have malignant strictures too, and there's a common reason for doing ERCP. So for this patient that we had talked about as well, we did his ERCP at the same session, and we found that he had so if you follow me here, you can see here for him, you can see that with the wire, we first of all went into his pancreatic duct with the wire going across the spine. So this was a pancreatic duct. we left the wire in there and we did a double wire technique where with the wire staying in here, it prevents you from going again into the pancreatic duct. And the next time we tried, we were able to go up and across. And so this wire going up here now is going into the bile duct for the patient. We got a cholangiogram here. You can clearly see that there's dilation of the common bile duct and also of the patient's intrahepatic ducts too. And how you can tell this dilation is that the endoscope is about 1.2 centimeters. And so if you assume that this width is this width here, you can be able to sort of guess, how wide this is. It's about 1.3, 1.4 centimeters here. But there's clearly distal obstruction here because everything just, closes up from here. We'll be able to place fully covered metal stents for this patient. And you can see there's a clear waist in this area. This is where we have the greatest area of compression from the mass and the pancreatic head. But with a covered metal stent, these are self-expanding metal stents. Over time, they open up some more to facilitate drainage of the biliary tree. This is another patient that we saw as well in Lagos, and this is another kind of use for endoscopic ultrasound. But it's a patient who came in who has had multiple scopes, and they've all seen this lesion that was concerning for a gist, but they couldn't tell for sure, so they referred the patient for evaluation. This patient was able to have an endoscopic ultrasound done as well. We showed a hypoechoic lesion measuring about 4 centimeters, which was biopsied, and pathology came back, and it was consistent with a gist. The reason I highlight this is that EUS is important for staging tumors in the stomach and the esophagus and the rectum as well. And we can have so many tumors that appear that like they might be GIST, but they're not always GIST. And the reason that we're able to use endoscopic ultrasound to really tell what's going on is that with EUS, we can clearly tell what layer of the GI tract this is coming from. Is it from the mucosa, submucosa, the muscularis propria? They are different, they all look differently on the endoscopic ultrasound. And depending on where the lesion is coming from, whether it's the first, second, third, or fourth layer, you can hazard a guess as to what it could be. But the most important thing is if it's sizable enough to do a biopsy and send it to the pathologist. That way, that helps to guide what we're doing going forward. Now, there are other things that could be happening besides the gist. What if this was a lipoma, right? If this is a lipoma and the patient doesn't need surgery, if this is a leiomyoma that had no malignant potential, then nothing to do. But if it's a gist and you can tell the mitotic index of the gist, that helps to tell you how fast we need to act. So EUS is important for evaluating subepithelial gastric lesions as well. This is another patient that we saw, 64-year-old man who was referred for evaluation of obstructive jaundice as well. He had MRCP done, which had revealed some dilated ducts, and there was concern for soft tissue mass involving the region of the common hepatic duct and the gallbladder neck. The CA99 was also very high, and the concern, before the procedure was this could be cholangiocarcinoma. We went in for his procedure, and we can see here with the fluoroscopy pictures, contrast was injected, and you can see a lot of dilation of the intrahepatic ducts, and there was a clear stricture in the common hepatic duct area for this patient. We placed a plastic stent to bridge the area. There was good drainage, but before that, we also did brushings as well, because when doing an ERCP, you can take brushings and send cells for cytology that can help you to confirm that this is cholangiocarcinoma. For this patient, we weren't able to get a positive diagnosis, and as we know, with cholangiocarcinoma, these are really difficult to get tissue sometimes. The ideal thing with these cases is to do what we call cholangioscopy, where we use very tiny baby scope that can actually go into the bile duct and take a look inside the bile duct and use very tiny forceps to actually biopsy the lesion. We don't have that yet, but that's the ideal going forward. But just based on the patient's scans, the findings during his procedure, the high CA99, at the tumor board meeting, we agreed that it was reasonable to start treatment for cholangiocarcinoma for him, and he's done well so far on his treatment. Now, besides this kind of stricture that I described as more proximal, we can also have distal biliary strictures as well. Some of the malignant ones we see include strictures from pancreatic cancer, from cholangiocarcinoma, from ampullary cancer. We also have benign causes as well. People that drink heavily, they may have chronic pancreatitis or autoimmune pancreatitis. The inflammation can cause a little fibrosis, and we know that the duct runs through the pancreas, and that can cause strictures that need therapy as well. And this is what a typical severe malignant appearing distal bowel duct stricture looks like. We can see the tip of our scope, and there's a long, tight stricture here, while there's dilation of the proximal duct here we're feeling. And with this kind of case, we place the stents to bridge it and help with decompression. Now, we can also have obstruction in the hilum as well. And with obstruction in the hilum, causes could include cholangiocarcinoma. That's one of the more common causes we see. We can have liver metastasis, gallbladder cancer, and there are also some benign indications like we see here. With this kind of strictures as well, the first course of action should be to do ERCP to see if we can try to breach through, and in this case, is place stents in both the left and the right hepatic ducts to help with drainage. Now, for patients like this, sometimes we see them, they're very sick, and the question is, should we really be doing something if we think this is malignant? Especially in our setting where resources can be an issue. But all the studies have shown that palliative biliary decompression is important. It improves quality of life. It helps to improve jaundice, pruritus. Most of these patients are just really, really in a bad shape when they come in, and palliation is important for them. And we should always try to provide decompression where this is possible. I know that before now, a lot of the decompression that we've done in some centers have been having to do surgery and do triple bypass. But most of these patients are really sick, and many of them, do not do well in terms of just the post-surgical complications. And when we can do things minimally invasively like this, this should be the ideal. There's another patient that we saw, a 54-year-old woman who was diagnosed with gastric adenocarcinoma, and she was referred to us for evaluation of gastric canal obstruction. She hadn't been able to eat or drink for about 2 months before now, had lost a lot of weight, and the surgeons had tried to do a percutaneous jejunostomy, but this did not work very well, and the patient wasn't a surgical fit for gastric jejunostomy. So we spoke with the surgeons. We decided, okay, let's see if we can get a gastric stent in this patient to help with patient's nutrition. Now, just to give some background, gastric cancer, as we know, is the 5th most common cause of cancer deaths worldwide. In some countries on the African continent, like in Mali, for example, is the most common cancer in men. And we know that the reason why we see a lot of gastric cancer in Mali and some other African countries, that H. pylori is prevalent in the environment. In Nigeria, for example, I think our numbers is like about 90% H. pylori seroprevalence rate for us. And so this, I think, is the main risk factor for this. And with these patients, most times they present late. When you do their scopes, you can see the cancers in different forms. This first one, for example, is a large ulcerated lesion. There's malignant, but you can also have it like in this second or this third picture where you have just a lot of tumor filling up the entire lumen and causing them to have symptoms of gastric outlet obstruction. And for this patient, she had something similar. So for this patient, what we did was that we were able to, under combined fluoroscopy and with the endoscopy as well, go in and place a metal stent, a self-expanding metal stent that was able to open up over time and allow this patient who hadn't eaten for 2 months by mouth to start eating. And the patient was able to improve her nutrition, went on to have chemotherapy. She had done like 3 or 4 cycles of chemo. Now, the last time we saw her, she had gained weight, doing well. But, this sort of helps as a bridge to get them to the next stage in their care with this advanced interventional endoscopic techniques that we can do. This is another patient that was referred to us, a 78-year-old man with a history of prostate cancer, but he was sent because he also had gastric outlet obstruction as well. And he had a CT that was done that was concerning for a mass in the pylorus, but they couldn't tell if the mass was coming from the pancreatic head or if it was separate from it. Because he also had this history of prostate cancer that they were treating, the concern was, is this metastasis? But his PSA was normal. And so the question is this a new cancer happening in the pancreas for this patient as well? And so the plan for him was to do 2 interventional procedures at the same time. The first one was to go in and see what's going on, but try to do an endoscopic ultrasound as well to evaluate for what we're seeing. With the first picture, you see that when we went in, this is looking into the prepyloric section, and you can see there's this evidence of extrinsic compression happening there. We went into his duodenum, and you can see that the duodenum is all fully infiltrated and narrowed, and it looked like it was coming from the outside, not something happening within the lumen itself primarily. We did endoscopic ultrasound, and we found this lesion, which was about a 5-centimeter mass in the pancreatic head. We were able to biopsy it, and pathology came back and confirmed that this was a pancreatic adenocarcinoma. So we knew that this was the primary. But at the same session as well for him, we're also able to place a stent and place a gastric stent. And like I said, we do these procedures under fluoroscopy and under endoscopy as well. The reason why fluoroscopy is important is that in most of these cases, you can't get through the obstructions to see what's going on behind it. But with fluoroscopy, we can get a wire across, see where it goes, inject contrast, and know that we're in the right place before we eventually deploy the stent safely under fluoroscopy. Some of these things you see here with the pins here is what we use to mark where we need to get to with the stents. There's another patient that we saw who was referred for evaluation of cholangiocarcinoma. And this patient had come in with reports of just frequent chills over time with these episodes of jaundice that were coming and going and then pain in the abdomen. It wasn't a persistent episode of jaundice. It comes and goes, comes and goes. His viral hepatitis B and C panel was negative for him. The patient had scans done as well, and the multiple scans that he had shown different things with the scans, multiple CT scans and multiple MRI scans. But there was one that was sent, one of his films was sent abroad for them to give a second look, and they had reported that there was subtle intra and extrahepatic bile duct bleeding seen concerning for some inflammation within the biliary tree. His liver numbers were increased but not markedly high. But for him, what was impressive was his GGT was really high, and his alkaline phosphatase was also very high as well. His CA19-9 was 327, so that was high. So the concern before we saw him, when we saw him, was this could be cholangiocarcinoma. But with the scans showing the beating of the bile duct, we thought, well, this could be something else as well. We went on to do the patient's ERCP, and you can see here that we were able to, we also had one wire in the patient's pancreatic duct. This is going across the spine, but we also have a wire going up here into the patient's bile duct as well. We injected contrast and got a cholangiogram, and you can clearly see for him here that there is a stone in the patient's distal common bile duct here. But besides this stone that we see here, we also see that the duct has sort of this raggy, jagged appearance that the duct has, not quite the way we see the ducts look. And let me show you this other picture here. So with this picture here, we see sort of what we call like a pruned tree appearance. That's not how this typically looks. And whenever we see this appearance, the primary differential that we have is what we call primary sclerosing cholangitis, PSC. So for this patient, we're able to extract the stone, then we place the stent in his bile duct as well for drainage for him. Now with PSC, this is a chronic immune-mediated cholangiopathy that over time causes multiple strictures within the bile duct. It increases the risk of cirrhosis and cholangiocarcinoma in these patients. The risk of cholangiocarcinoma every year for them is 1 to 2%, so it's very significant for them. And 60 to 80% of patients that have PSC also have concomitant inflammatory bowel disease. In most cases, they have ulcerative colitis. For them, the first line is to do their scans with the MRI for diagnosis. If that is not giving us a diagnosis, then we can do ERCP, which, like in his case, wasn't just diagnostic, but also therapeutic, because we found the stone that we removed and then placed a stent for him as well. With PSC, there is no cure for it. Transplant is the only real cure for these patients. We can manage their symptoms. If they have pruritus, for example, cholestyramine can help. If they have a dominant stricture, you may dilate it or place a stent for a short period. But for them, it's really important that we do surveillance for them. So for this patient, for example, our plan is to bring him back very soon to do his colonoscopy to see if he has ulcerative colitis. And if he does, then he needs to be on an annual plan to screen for colon cancer because the risk is so high in them. There's also a risk of cholangiocarcinoma, and so his plan will be to get CA19-9 and repeat the MRCP every year for him. So another patient that was...
Dr. Kenechukwu,
yes.
I'm so sorry for interrupting. Is it possible to round up in the next 5 minutes so that we can have time
Yes.
for Q&A?
Sure.
Thank you.
Yeah. There's another patient that we saw who was referred for evaluation of severe chest pain and difficulty swallowing. She had a barium esophagram that was concerning for web in the proximal esophagus. And she had been seen by some of my colleagues previously, had scopes done, but they couldn't get past the stricture. So they sent her to us to do a dilation for her. And we went in, and you can see from this first picture just how narrow things were looking here. Even the neonatal endoscope could not pass through because it was that narrow. We did savory dilation up to 7 millimeters, and we were able to have a small tear through, and we were able to get the scope down. Once we got the scope down, this is what we found. She had about a 15 cm length of just malignant appearing lesion in her esophagus. We biopsied this, and this came back as squamous cell cancer for her. And so she's been sent for treatment. And just very briefly, in terms of cancers involving the esophagus, these are more common in the eastern part of the continent. Malawi has one of the highest incidence rates that we see. And there's this region called the esophageal cancer corridor where we have the highest rate of esophageal cancer in the world, or mostly squamous cell cancers that we see here. This is the last case, similar patient as well, who was diagnosed with cancer involving the esophagus and the stomach and had significant dysphagia, couldn't handle his secretions, and was referred to consider esophageal stent placement this time. For him, this was his endoscopy. You can see going down, this is the proximal esophagus. Things looked okay. As we got down, we can see that there's clearly a lesion here. And this is where most of the obstruction was for him. We were able to eventually get past this with some resistance, and we were able to eventually get into the stomach just to see as well what's going on for this patient. We were able to afterwards place a stent for him, and this was a stent that also bridged the GE junction as well to really enable him to handle his secretions, begin a liquid diet, and then go on to have improved nutrition to be able to get his cancer treatment. We can see here that we have a clip that's holding the stent in place. The placing these clips just helps to prevent the migration of the stents as well. So just to summarize, GI cancers contribute to about a third of cancer deaths globally. And on the African continent, the case fatality rate is high because primarily we have delayed diagnosis for our patients. Cancer care, as we all know, is a group effort between the surgeons, interventional endoscopists, radiologists, the oncologists, and we all need to continue to work together to provide care for our patients. And using more minimally invasive approaches and techniques is ideal, as most of these patients usually are very sick, and the most minimally invasive thing will just help them to recover faster. Some of the key procedures that we've talked about include ERCP, EUS, GI luminal stenting, and the field is growing and we're seeing more and more. But I wanted to just share this with us just so that we can appreciate some of the things that are becoming much more available now. There's still a need for us to train more people, have more centers perform these procedures as well. And this is something that, I hope that the society can help us work on over time, to provide more training and have the services be more available for our people. Thank you everyone for listening, and I will stop at this point. This is our center here in Lagos at the Reader Center for Digestive Health, and this is just some pictures from our center. But thank you all.
Thank you, Dr. Kenechukwu, for this good talk on interventional endoscopy for digestive malignancies. Without further ado, I'll just hand over to Dr. Egwari to handle the Q&A session. Thank you.
Thank you so much, Dr. Kenechukwu. This is just such a fantastic presentation. And the pictures, the standard of presentation was just excellent. Thank you so much. Well done. And it is obvious that you put in quite a lot of work in this just to bring this to us. Thank you so much. I'm just a bit partial here. As a colorectal surgeon, you've really gone to town with the upper GI pathologist. And you start with the adenoma carcinoma sequence of the colon. I'm just interested in terms of your interventional procedures you do in the center for colorectal diseases. Will you be doing the stentings just as you've just shown us the fanciful work you've done in the esophagus and the stomach?
Thank you, sir. Thank you for your comments. Yes, so we do procedures that include EMR. We do stenting as well. We haven't done our first stent case yet in the colon. We haven't done it yet. And for stents in the colon, the patients need to be well selected. These need to be patients, in most cases, where it's either just palliative, death is imminent, and we want to make sure that they're not obstructed, or for patients where it's really just a bridge to surgery. You want to do surgery soon, we can't clean them out. We want to be able to open up and try to decompress them before they go into surgery. We haven't had the right patient yet who we have felt that, this is what they will need, but we have the stents and we can perform it. For these cases as well, it's much more ideal if it's a left-sided tumor that we're trying to stent and then, have this happen. It's a little bit more complex trying to get a stent on the right side of the colon. But we just haven't done it yet. We are not performing ESDs yet. Primarily, because it's much more complex. We need much more surgical support for it, but that's something that we hope to start doing soon. We have some of our partners here that do ESD that come from abroad who definitely can do them. We just aren't doing them yet.
Okay, great, thank you. And just another point you talked about. You said you use the endoloops for tying up the stalk of the pedunculated polyps, to reduce the risk of bleeding. I was just wondering, because when you consider, like the pictures you showed, the Hargate classification of pedunculated polyps in terms of the propensity for malignant invasion of the stalk. Because once you put an endoloop on the stalk, then it reduces your ability to completely excise the stalk. So is this a problem that you end up leaving potential malignant tissue behind?
Yeah, that's really important, sir. So with this polyps, the goal is to place the endolobe at the most distal portion of the stalk, so as low as possible. And just based on your visual exam, you can typically tell if there's some invasion, how far down that goes in the stalk. But in my experience, it hasn't been much of a problem. Most of these polyps look benign, the stalk looks okay, but this makes a big difference in reducing their risk of bleeding. If it is a concern, you can do without the endolobe and just inject, epinephrine into the stalk and then just take everything out completely. But in terms of how much tissue is left, if you place it really low, there's really not that much tissue that's left, approximately.
Okay, and will you consider using clips to oppose the mucosa or to reduce the risk of bleeding?
Before resection?
Oh, after. When you have it.
Sure. Well, so if you do it with the endoloop, you may not need a clip. If you don't do it with the endoloop, definitely place a clip to reduce the risk of bleeding. But I actually have seen some cases where we actually placed a clip. If you don't have the endoloop, right, you place a clip before you resect. So, and that just holds on the stalk before you do the resection as well.
All right. No, that's great. Thank you so much. I mean, it's been a very exciting presentation. I think there are some questions on the chat. We'll go through the chat together and see how many of these we can go through before the president takes over. Yeah.
Oh.
Do you have a visibility of the chat?
Let me open it up now and see, sir.
Yeah, I'm just looking through. Okay, there's a question from Dr. Babajide Oladeyo, and he says, I would like to know the best choice of stent, plastic or metallic, to use for patients with malignant biliary obstruction prior to surgery, WIPOs, then pros and cons of covered and uncovered metallic stents.
Yes, so the surgeons that I've talked with for WIPOs, whether it's a plastic or metal stent, they're able to take it out during the procedure. It's not a problem for them. If it's a more proximal stricture, for example, we have a patient who there's a concern for proximal cholangiocarcinoma, and the patient wouldn't need a WIPOs, they'll need more like a proximal bile duct resection and possibly have a hepaticojejunostomy done. A plastic stent would be preferable in that instance compared to a metal stent. In terms of when we do an uncovered versus covered metal stents, there are things that we consider. So with a covered metal stent, when you put it in, it's completely covered. If this patient, for example, has a low cystic duct takeoff, there's a potential risk that the covered stent can obstruct the cystic duct and increase their risk of developing cholecystitis. That's something that we don't want. And so if you see a cystic duct that's very low, I will do a non-covered metal stent in that case. But if that's not a problem, then you can do a fully covered metal stent. The other consideration is at the point of doing your procedure, do you know for sure that this is cancer versus non-cancer? What if this, for example, is chronic pancreatitis causing this, and you want to plan to take out the stent at some point? If you put a non-covered metal stent, you're going to have tissue grow into the stent such that you can't take it out ever again. So in that case, putting a fully covered metal stent is ideal. That way, if it's benign and you need to take the stent out, it can come out easily, no issues with it. So these are all the considerations that go into it: covered, non-covered, plastic, non-plastic.
Great, thank you very much. And the other question I just want to find out, if you're anticipating that you're going to do a hepaticojejunostomy for a patient, I would have thought one of the teaching is that you don't, in as much as you're anticipating early surgical intervention, you don't decompress, especially with a PTC or but I know you want to relieve symptoms of jaundice and pruritus and the like. What is your view? Do you want to allow a dilated loop to enhance your success in your hepaticojejunostomy?
So this patient in particular that we talked about, they came with obstructive jaundice. It wasn't clear what the diagnosis was, and the goal was to relieve jaundice. I will let the biliary surgeons, chime in here if they, in terms of their thoughts. But I do not believe that a plastic stent should significantly affect the success of their surgery or make it more challenging in terms of the technique that they do. Metal stent is a completely different issue, but for a plastic stent, I'm not sure that it should impact them less significantly. And we want to relieve these patients beforehand. Relieve them. Most times they need to have chemo first to, reduce the tumor burden before they become candidates for surgery. And most of them need to have their bilirubin come down significantly for chemo to happen first. So I think that biliary decompression should be a primary thing we do before we continue further in their care.
Okay. And for those patients that it's not possible for you to do a biliary dilatation, the bridging transhepatic, is that an option, or do you have the experience of that? Is that something we'll consider also?
I'm not sure I understand the question. So can you repeat? Can you rephrase me?
I agree with you that the plastic stent for the common bile duct, is the preferred option, but sometimes the stricture is long and it's difficult for you to bypass that.
Okay.
And in which case, then you want to do a percutaneous transhepatic drainage.
Yeah.
Is that an option also if you have this? I don't know what the experiences are with that.
So with more experienced hands, the biliary cannulation rate is about 95 to 99%. And so in most cases, we're able to get through to cannulate and get past it. In my experience, just in Nigeria, Rwanda as well, where I practice as well, we know that most of our patients present very late. The tumors are, much bigger. It's much more challenging with their procedures. And so there are times when we fail to cannulate with these patients. When we fail, we typically let them rest for 2 to 3 days, let the swelling improve, and try again. There are different things that we can do to help us to get into the duct. We do sphincterotomy to cut through to try and get in. But if that all fails, then we invite our interventional radiology colleagues to do a PTC, to go in through the liver to try and get this done. But that should be something that we try after we fail to go in below. Because as you know, we're going through the liver with the PTC, there's risks that come with that as well.
Yeah. Thank you so much. There's a question from Dr. Chudy-Onwugaje, and it says, what do you do if an endolobe fails to detach after the lobe is applied?
So it's not supposed to detach right after you apply it. It's something that falls off on its own in a few weeks. You just apply it, it stays there, it holds things in place, you resect the polyp above it, and you leave it in there. And just the way your clip falls out after a few weeks to a few months, that comes out and goes out in the stool. So we don't check for it, you just leave it there.
Yeah. And it's just the same lobe we use for appendicectomy. This is it's it's made of absorbable material. So it will eventually dissolve or fall away anyway. And Dr. Christian Ungu is asking a question here. Thank you for the detailed presentation. In those with esophageal squamous carcinoma, does radiotherapy affect the stent? Following the resection, and there is a mucosal breach, how do you take care of the perforation? How do you objectively measure the diameter of the polyp in endoscopy? Thank you.
All right. Thank you, Dr. Christian. So after we place the stent, it shouldn't affect the patients being able to get radiation therapy. That shouldn't affect it at all. They can still get radiation therapy. In terms of how we take care of perforation. So this is something that whenever we do procedures, we should just prepare for. If you have a perforation, depending on what size it is, we want to be able to identify it when it happens, try to get a sense of the size of it. We can use clips if it's a small perforation of about 1 centimeter to really close it all. Multiple clips to close the perforation. In places where we have it available, we can also do endoscopic suturing as well. We don't have it yet at our center, but in the US and the UK, they have this sense and they can use it to close the perforation when they're in there. If it's in the esophagus, right, and you have a perforation, what you simply do is you place a fully covered esophageal stent. Because it's fully covered, it bridges the area where you have the perforation. But because it's covered, there is no leak going into the chest cavity. And over time, the leak seals itself because you have that fully covered stent that's there to bridge it. And if all else fails, we invite the surgeons to come and help us with taking care of the perforation.
So can I just, I'm so sorry, can I just chip in here? We have
Yes.
an agent to go on after this webinar, and there are at least 4 hands raised. Can I suggest that after you take this last question, we can address the hands that have been raised? They've been patient for a while now, for the next 10 minutes, and then we'll start the AGM. Other questions in the chat, if you could just please respond to them directly in the chat so that we can also see them too. I think that will help us save time. I don't know if that's a good idea.
Okay, yeah, that's fine. See, because you haven't stopped sharing, we can't see the participants who are raising their hands. Okay, now we can see them. Okay, now I can see the hands. And Dr. Kenechukwu, you have a question?
Yes, I do. Thank you for the presentation. My question is related to the last question, which has not been addressed. How you estimate the sizes of these polyps, especially during colonoscopy? How do you practically estimate your own sizes? Because this has bearing on the interventions that you do. And do you go about biopsying all polyps that you encounter during colonoscopy? If you have polyps that look clearly benign, maybe hyperplastic appearing polyps, do you go about biopsying all of them? Thank you.
Thank you for that question. So the way we try to estimate it, so you know your biopsy forceps, right? When you open your biopsy forceps and open jaw for the outward biopsy forceps, it's about 8 millimeters for your open biopsy forceps. So whatever polyp you see, just think about your biopsy forceps. You can use your forceps to oppose it and use that to measure it. Over time, you get more experienced, but just think about the open biopsy forceps and that being about 8 millimeter wide, and that's what you use. If it's a pediatric biopsy forceps, that's about 6 millimeters wide, and that's what you can use in your mind as well to try to measure the size of what you're seeing.
Okay, thank you very much. And Professor Rayofo.
Thank you very much, Dr. Kene. It's really gratifying to know that you are doing so much for the population in Lagos and even beyond. I just want to, and it's a short period to cover the entire ground, but I commend the presentation. It's really been excellent. I just want to, I'll dwell a bit with the colorectal and regarding the polyps, localization, characterization before the resection. If you could share some tips so that people can easily diagnose lesions and in technique. And then in terms of characterization, are there things that can make it easier? The last question was on hyperplastic and on hyperplastic polyp. Are there ways to make it easier to diagnose and leave and resect and discard? You know, and then when you've characterized the lesion, it's good to advise on younger colleagues being a bit circumspective about their ability, or so that that idea of tattooing and referring to an experienced interventional endoscopist comes up. If you could comment on this, I wouldn't go with the ERCP so much, just trying to stay focused to the Colorectal Society. So the endoscopic ultrasound, yes, I wish you could comment on your experience with its use in rectal lesions, if you've ever had cause to get referrals for such, because yes, it's ideal for very early stage compared to the much used MRI, but just if you could comment a bit on your experience with the use of that in rectal pathologies. Thank you.
Thank you, Prof. So regarding the features that we see that are concerning, so there are a few things. Number one, size. Anything above 1 centimeter is considered to be an advanced polyp. If it's above 2, it's even much more concerning. But besides the size, you're also looking at things like, does it look like it's tethered to the mucosa, to the submucosa? Is it an ulcerated polyp? What else is going on with it? Does this polyp lift when you try to lift it? These are things that are concerning as well. This could be malignant or not. But besides that, even for polyps that you clearly think are not malignant, all polyps should be taken out just in general, except if you clearly see them. Polyps in the rectum mostly, sometimes in the sigmoid as well. You can see this polyps that are hyperplastic. With experience, we know what they are when we see them. They are always very tiny and very small, and they're usually multiple. When you see those, you can sample a few of them just to confirm. But besides that, every other polyp that you see should be taken out. If you don't have the experience, you want to refer to someone that can. But polyps should never be left in the colon. Now, the other thing that I want to caution everyone, which I'm sure most of you have experience with, is also the pathology, the person that's going to read the path for your polyp. Because we haven't had a culture of colon cancer screening, our pathologists aren't seeing 1,000 polyps in a month to read through and to interpret. So in my experience here in Lagos, we've had some labs where we've been sending polyps to where all the polyps that we see, when we take them out, to clearly know that this is an adenoma, and the pathology which comes that can say is an inflammatory polyp. And these are patients that have no inflammation in their colon at all, and that made no sense. And we had to give feedback to the pathology team when this was happening with. They had to retrain their colleagues. So who is reading your pathology is really important. We don't want to see an adenoma, which we know if that is the case, it affects the surveillance for this patient, and call it hyperplastic and do nothing about it, or call it an inflammatory polyp. So that I think that part is key, and it's something that we may all do well to talk with the pathologists at our local centers about this as well. Regarding endoscopic ultrasound for the rectum, we haven't had any request here in Lagos. And with that, when we do that, there's a special probe that is used for that. We don't have that probe, but in my practice abroad, yes, we've had requests for endoscopic ultrasound for the rectum, but we haven't done it here yet. We don't have the probe for it here.
Thank you very much, Dr. Kenechukwu. And I think it's so important for you to have highlighted that point. Every polyp, they should be taken out. Whether I think whether it's hyperplastic or moderate dysplasia, whatever it is, that is a histological characterization. And
sorry, can I make a comment on that?
Yes.
If you have a polyposis,
that's the exception. If you have hundreds of polyps, you can sample those. But where we are talking in terms of polyps now, we just can't make judgments that some may be hyperplastic and you leave them behind. And I think if you have the resources to take them out, apart from the adenoma and the polyposis, where you have hundreds of them, where you can just sample them, but I think it would be instructive that we should endeavor to take out the polyps.
Can I just add here before we go on that I think that this is a good chance to bring up that for this society, it will be important for us to really begin to promote colorectal cancer screening for the general population. We're doing it for breast cancer, cervical cancer, given how much we're seeing and how much younger we're seeing this. I think it's a mandate for our society to think about how we can make this also be as more commonplace in the country as general cancer screening, sir.
Thank you.
I'm so sorry, sir. I'm so sorry, sir. Can I really step in here? We really gone past the allotted time, and we still have the AGM. Is it possible that the questions are typed out on the chat function and they're responded to, sir?
Okay, we just go through with the last two there, Dr. Chudy-Onwugaje and Dr. Okeke, and after that, we can round
up. Sir.
Those hands have been up for some time.
Good afternoon. Yeah. Good afternoon. Can I go ahead? Good afternoon. Yeah, Dr. Chudy-Onwugaje. Good afternoon. Dr. Ken, superlative presentation as usual. Can you hear me, please?
Yes,
can. Yeah, superlative presentation as usual. I just have a question for you. I mean, this is a real life situation. I have an 87-year-old lady. She has gastric outlet obstruction. She has obstructive jaundice. She's 87. And is it possible to stent the gastric outlet obstruction and to stent the biliary tree at the same time? Is it possible?
It depends. It depends on the obstruction and how severe it is. The idea will be, if it's not complete and the scope can get through, to try to stent the bile duct first and then place a duodenal stent for the gastric outlet obstruction. But it would all depend on how severe things are. But this can be done to do them both at the same time, yes.
All right. Thank you. Thank you very much. Superlative presentation as usual. Thank you, everyone.
Thank you. And Dr. Okeke, CJ. Dr. KK, can you hear us? You're muted. Okay, so it looks like we can't get Dr. KK. Okay, he's unmuted now. Yes, Dr. KK, can you hear us?
Hello. Yeah, can you hear me, sir?
Yes, we can hear you now.
Okay, thank you very much, Kenneth. My own observation is that from the presentation, most of the pancreatic tumors you talked about, most of them are more than 2.5 cm. And I believe that most of them are not resectable and will be going for palliative treatment. My question is that the early pancreatic tumors, have you been identifying them in this country? And how do they present? Because as you said, endoscopic ultrasound scan tends to pick a smaller lesion than our CT scan. What is your experience? Have you been getting them, and how have they been presented in this environment?
Thank you, sir, for that. So, I always say in my mind, I tell people that the best place to have a pancreatic tumor, if you have one, is in the head of the pancreas. Because soon enough, even while it's still small enough, it will cause obstructive jaundice and it presents itself. Compared to the tail, where we can have a lesion go up to 6 centimeters before we really get to it. So for the tumors that are early, if they're in the head, we can have jaundice, like the patient that I talked about, I think it was the second or the third case that had the 2.7 centimeter pancreatic head neuroendocrine tumor. He came in with jaundice. That was the main thing, but there was no features of metastasis. Everything was just localized for him. We placed his tank, 2 biopsies. He had his Whipples done. Thanks to our colleagues at the University College Hospital, he had his Whipples done. He's doing well now. So we can pick some of these things early enough when there's no spread and it's still localized. And thankfully, we have the skill set for Whipples in the country, and this is being done. We definitely, of course, need more volume and need more centers to do it to be able to achieve cure in these patients. But to your question again, the early symptoms that we see is if it's in the head, they have jaundice, it presents itself. If it's in other parts of the pancreas, sometimes they come in and it's too late already. And there's local invasion, metastasis, and it's much harder to achieve a cure for them.
What I really want to know, have you been getting these smaller tumors? Have you been seeing them in this country? Smaller tumor like 1 cm or less than 1 cm? Have you been seeing them in the country?
Yeah, so we haven't, I personally haven't gotten any 1 cm or any of that. Our center has been in existence, within we started services this year, so we haven't seen all kinds of patients. I think it really will depend on the people that are reading the CTs, identifying them and then sending them to us, but we haven't seen as much of those yet. But if people have jaundice, that's really the first thing that will let them know they should come to us for something.
Thank you so much. I'm conscious of the time now, and I just want to thank Dr. Kenechukwu-Onwugaje for this fantastic and erudite presentation. At the height of the presentation, there were about 100 participants, and I think that's a record, and I think that's just a testament to the importance of your presentation today, and you did not disappoint. So I thank you so much for that. There are still a lot of questions on the chat side. So my appeal will be that following this meeting, because of the AGM we're going to have, we have to terminate the conversation at this point. But if you will, just oblige us to provide answers to those questions on the chat, that would be appreciated. So on behalf of the association, I want to thank you once again. And I hope that this will be a long-lasting collaboration and relationship with your center and with our practitioners who are here today. Thank you so much. And at this junction, I'll hand over back to Mr. President. Thank you.
Thank you, Dr. Egwari. I'm very grateful for how you've anchored the Q&A session. And again, thank you to Dr. Kenechukwu for the erudite presentation. We're indeed grateful. As he said, please help us to attend to the questions in the chat so that everybody will feel attended to. So without further ado, we'll quickly move on to the AGM, which will be brief. So I just indulge our patients to just wait for a while.